Hi, I'm Elsa Sandset. I'm a stroke neurologist from Oslo, and it's a pleasure to welcome you here to Basel with this great group of people this morning. We have Robin Lemons, the chair of the ESO conference. We have Stephanie Debet, the co-chair, and we have two representatives from the local organizing group, Mario Sikogios and Philip Lear. So welcome, and how are you this morning?
Fantastic.
We're fine.
That's good,
Great.
that's good. So it's been 2 days with beautiful sunshine in Basel, and today, as we all have moved inside, and we're supposed to be here all day inside, there's a bit of rain, and there will be sun again this evening, won't there, Philip?
Yes.
You ordered it
So
for
you
us.
plant everything.
So, Philip, can you tell us a bit about, I think you were elemental in getting the conference to Basel. Can you tell us a bit about
Yes,
how you got the conference to Basel,
Yes.
and why it's important for you to have the conference in Basel?
So, being here locally as stroke neurologist at the university hospital and raised up the stroke center, and also having done many work within ESO in different committees, we decided, when I stepped down as president from the Swiss Stroke Society, to bring ESO once to Basel. So my very important reason was that ESO is domiciliated in Basel, as Association Management Congress is domiciliated in Basel, and it settled down in 2012 in Basel. Personally, I had to sign that that's a wealthy organization and everything is okay with it. And so you see how it developed, and later on we decided that the 10 years Congress could be here in Basel. And so we submitted actually 3 times to get the Congress here in Basel. Now we are here, and I really very welcome everybody here in Basel. Basel has a long tradition with medical sciences and with life sciences. As you may be aware, there are big companies settled down here in Basel, and so now we have the ESO Congress here in Basel. Congratulations. Thank you for coming here.
I think it's great, and Basel, we already experienced it. I've been here since Monday, and both Monday night and last night when I was out for dinner, you meet people from the conference everywhere in the streets, and that is so it creates a unique atmosphere being in a bit of a smaller city where basically stroke has taken over the city, I would say. So Marius, you're also based here.
Yes.
And you also, your day or your conference started yesterday, didn't it? With
Exactly. We had a pre-ESOC meeting, the Distal Summit. As you know, stroke is interdisciplinary and interprofessional. So we are living it also here in Basel like this. We are collaborating very nicely with neurology. I'm a neuroradiologist. And so yesterday we had if you want, interventional meeting, but with a lot of neurology aspects implemented in there, because we do the distal trial. It's a randomized trial that we run in Europe. And we gathered a lot of experts from around the world to discuss about distal occlusions, the treatment of distal occlusions, and how we can plan the future with meta-analysis on the trials that are coming, etc. So it was a very fruitful day, and yeah, I'm excited for the ESOC.
So, but Marius, your only role is not being an endovascular specialist, I think, for the conference. We all know it's also a big social event, right? Els was talking about having dinner. So you're also responsible for some elements in the program which are not maybe directly known to people, so to keep healthy. So can you talk a little bit about that?
Yes. So my team organizes the stroke run, and kudos to Lucia Balmer, who's done a great job on this organization. So this is going to be on Thursday at 7 a.m. And we are going to have 2 groups, a 5-kilometer and a 7-kilometer group. So if you want to be part of the stroke run, just be in front of the convention center at 7 a.m. And also, you know, since we discussed yesterday, you and I used to play a little bit of basketball. We thought that we have another event, you know, maybe if it's raining, people want to go inside. So we have a basketball game today, actually, at 7 p.m. So yeah, we try to get to stay healthy during the Congress.
Exactly. It's not only about science, but also about exercise, right?
Definitely. So you said multidisciplinary. Stroke definitely is multidisciplinary, and this conference is very international. Can you tell us a bit about the number of delegates, Stephanie, and some of the highlights of the program, maybe?
Yes. Well, first of all, thank you very much for hosting us. We're really thrilled to be here in Basel. And very proud with Robin, and I think all the credit goes to Robin, but we have 4,600 attendees, which is quite amazing. I think it's the second largest, isn't it, since the beginning of ESOC in the past 10 years, so quite an amazing number. So we have also very diverse attendance. First of all, I think we've tried to structure the program in a very multidisciplinary fashion, and also having speakers from across the world, from within Europe, across Europe, but also outside of Europe, and from other disciplines. Also very proud to see that among the top 10 countries attending, they are not only European countries, but also non-European delegates from the United States, from China. We have also very large Ukrainian attendance, which is wonderful. So we are really very happy and looking very much forward to these coming days.
Yeah, definitely. I think also the international aspect is shown in the abstracts that were submitted. Of course, we typically have a lot of European countries where the abstracts are coming from, but also here we see the top 5 countries, which are 2 non-European countries, which are also China and US. And so I think that also speaks for the conference that it's truly international and attracting globally people here to not only attend but also to present their work, which is excellent news, I think.
And Robin, you have been quite busy leading up to this conference. So now we're here, and what are the things you are looking most forward to?
Well, I think the important element is, like we're talking about the basketball run, the basketball and the run, and I think that speaks to the fact that it's also a social event. And we talked about that also last year because we went fully on site and not the hybrid format, and again we're doing this fully on site. I think it's not just about it's of course about the scientific presentations, and we'll talk a little bit about the trials I think hereafter, but it's also about bringing so many people together and meeting people again, and this can initiate collaborations between people, young people, like early, mid and late career. I think and this conference is ideally for people to meet, so I'm looking forward to that. But of course we're also looking forward to what's being presented, and so we had a huge amount of abstracts being submitted, so 15% more in comparison to last year. And also a lot of late-breaking abstracts. And typically, of course, those are randomized controlled trials that will be presented during the plenaries, and we typically have 3 plenary sessions, but the amount of clinical trials that was submitted was too large, so we could not fit it into the 3 plenary sessions, so we had to decide to basically design a 4th clinical trial session, and that's going to be on the Thursday morning, 8:30, so it's important for people to know that, because the plenaries are of course in everyone's agenda, but we have an extra clinical trial session at 8:30 on Thursday. And that's just because there were so many terrific submissions that we had to make it's a luxurious position to be in, I think, but they're very much looking forward to the clinical trials being presented. And what you hopefully will notice and see is that it's a very diverse program also in the plenaries. So it will be about prevention. It will be about primary and secondary prevention. It will be about interventions both for ischemic and hemorrhagic stroke again. And so it will be about rehabilitation as well. So we have the full scale of what we're dealing with, I think, as stroke physicians, also included in the plenary session. So very much looking forward to that.
And since you have in-depth knowledge of all these trials, what are you looking forward to most hearing about that will influence your clinical practice, you think?
So I think for many years the focus has been for clinical trials on the treatment of ischemic stroke. I think last year already there were these positive results as it was related to the treatment of intracranial hemorrhage. And we will again have trials being presented on the topic of intracranial hemorrhage and how to also improve outcome for those patients. So I think mostly looking forward to those ones, although of course everything is of interest. But I think to illustrate that the field is also moving towards a lot of progress for patients with intracranial hemorrhage. And that is something new, I think, in comparison to many years ago, where of course we had the great revolution of endovascular treatment for ischemic stroke patients, but hopefully we'll now see that also a same shift into indeed change of clinical practice as it relates to treating patients with intracranial hemorrhage, which you're probably looking forward to as well, Elsa.
No, I'm looking forward to that a lot, and I think it also, yesterday it was the first Intracerebral Hemorrhage Academy organized by ESO, where with the speakers, there were about 40 participants, specific topics on ICH, and also having younger colleagues present their research and getting feedback on that. So there's definitely a shift in our field with an increasing focus on ICH, which is much needed, and also hopefully we can make some progress in the treatment. So, and you, Stephanie, what are you looking most forward to hearing about from the program?
So I think I'm very much looking forward to the whole conference, which is extremely rich, and I particularly appreciate the diversity, because indeed we learn a lot from many fields. And maybe one thing to highlight in addition to what Robin has mentioned is that we've also tried to integrate basic science research and preclinical research in addition to the clinical part, and often intertwined in the same sessions, and I really like that a lot, because I think it brings in a lot of knowledge on the sort of mechanisms, and also opportunities maybe for future therapeutic developments that emerge from this basic work. I think there's which is perhaps a particular field of interest of mine, but on the genomics and omics side, a number of talks that are dedicated to sort of also giving some leads into how this can eventually bring in some novelties into precision medicine, into therapeutic developments, and yes, I think that there will be a very large panel of topics that will be suitable for every type of background in the audience. So, yeah.
And I think it's very important that you underscore the importance of having this variability in one session on a particular topic. I think that's a decision also that was made within the program committee, not to have like a preclinical basic science session on various topics, but indeed to merge that into sessions where maybe attendees will typically not have gone to the basic science talk, but if they're interested in the topic, it's informative to also hear about that, and that can indeed result to collaborations and insights that maybe you would have not thought of on beforehand. So I think that's very important that this, Stephanie has mentioned this, yes.
And I also think one of the new things on the program that has not been as present in the past is that we have several people who have suffered stroke on the program this year, with specific sessions dedicated to life after stroke, where we have the people we have treated in our clinical practice. And I think that is also, it's something about getting in kind of an overarching feel for the entire field, from the basic clinical science to the people who have suffered stroke, and we have everything in between, which is quite unique and fantastic with the conference.
This diversity is essential.
Yeah. And you, Marius, you of course, you're, we could say, you're a simple plumber, but a bit more than that. But your interests are more than that. What are you looking forward to the most in the program?
Well, I think the integration of interventionalists in the ESOC is really of importance. And I mean, I mentioned distal trial. This is a trial where the PI is a neurointerventionalist, and I think this is like a novelty in our field, that we also have from other directions people coming with ideas and trying to running trials. As Robin, I'm also very excited about the ICH trials. I think this is a really field where we can do a lot more. We have also started here trials with neurosurgery, for example, regarding minimal invasive evacuation, but also from even before that, you know, seeing a bleeding and trying to stop it before it bleeds further. Yeah. So we are doing work in this field, and I think it's really important to see the results.
Definitely.
So now, Philip, you've been going to all the conference, I think.
Yes, of course.
So you've seen a lot of change over the years, and so if you look back to ESOC, like your experiences over the years, so what strikes you the most, or what do you remember best of? Because we're celebrating also the 10th anniversary.
Definitely.
And so, looking back, so what are your thoughts about ESOC and the experiences?
I think what we learned is to specifically treat acute stroke. And this is very well settled down also with stroke units, stroke centers, and covers most of the countries that most people can get really an adequate treatment. My focus now is on secondary prevention and to develop secondary prevention in the way of personalized medicine. What does the individual really needs for his further life? And that's why we also had yesterday in the pre-ESO sessions one open session, open to the public, dealing exactly with this, what are the needs of the patients and the next of kin. And I think that it's the next steps that will come on the next years. Do more and do more specific in the secondary prevention, as well as we are very well settled for acute stroke treatment. And I think that's maybe the developments that we are waiting.
So you mentioned the event yesterday. This was about patient organization and stroke awareness.
Exactly.
So can you talk a little bit more about the initiative?
Yes, so we saw that actually we do not have a patient organization that is dedicated specifically to next of kin and patients in Switzerland. And this is amazing, as we have to do a lot for stroke, but it's also amazing that other countries around Switzerland, they already have it. And so we were thinking, how could we develop this? And we saw that there are many, many initiatives also in Switzerland, but they are heterogeneous. And so we will try to bring this together. And that's a new development.
So, and then a completely different question potentially, but people come to Basel, they may not be familiar with Basel. So they're looking now this morning and they're planning to go to the event here, but then thereafter they want to see Basel. So give us a list what we should not be missing when we're here.
Yes, that's a good idea, because actually there's a lot of history in Basel. You may be aware that it's a humanistic city. We had Erasmus from Rotterdam in Basel, we had Gutenberg who developed printing in the 16th, 17th century. The university is more than 550 years old. It was actually founded in 1460. So there's a lot of tradition. The Congress Center itself is almost downtown. So you can go everywhere just by walking. And you also have free access to tramways and whatever you want. And so there's the cathedral. There are almost 40 museums, many with modern art, with old art. And so there's a lot to do. So take the time to do this, beside, of course, stroke science.
Luckily, he's also advertising ESO.
Definitely. So I think this will end our session here now. I think we've highlighted a great program, a great conference. There's lots of people to meet from all different specialities, different backgrounds, different countries. I think talk to someone you haven't talked to before and enjoy the science, the city, and hopefully the sun.
Yes, enjoy ESO 2024. Good.
Hello and good morning from Basel, Switzerland. We are here at the ESO TV session led by Microvention. My name is Jens Fieler. I'm from the Hamburg University Hospital in Germany, and we are going to have 3 very good and interesting talks today about different aspects of interventional stroke research. And my first guest is Markus Müllenbruch. Markus is Director of Neurointerventional Radiology in Heidelberg, Germany, and please.
Yeah, good morning, Jens, and good morning, everybody. So the idea of this first interview is a little bit to talk about the SESAME results. This is a study which we conducted in Heidelberg, and yes, this is actually what we'd like to discuss. So here you see my disclosure. So for this study, we received a grant from BALT, but as you can see here, sorry, that was not a grant from BALT, a grant from Microvention, but as you can see, Microvention did not have any influence on the study design, data collection, or analysis. So the initial idea was to demonstrate that the use of SOFIA Plus catheter for direct aspiration as first-line technique is fast, safe, and effective in patients suffering a large vessel occlusion in the anterior circulation. So you see that this is a GCP trial. So it was conducted in 14 European centers, and all the imaging were evaluated by an independent core lab, and also there was a clinical event committee to look at the different clinical events which you see later during my presentation. So this is the flow chart of the patients. You see that we enrolled 250 patients, and at the end we analyzed the data of 246 patients. Here are some baseline presentations, which are, I would say, very similar to other registries. And the idea here of this registry was to look at 2 different catheters, so SOFIA Plus and SOFIA 5 French. You see that the majority of the patients were treated by using a SOFIA Plus catheter, which was probably related to the fact that most of the patients had an M1 occlusion or a carotid T occlusion, and only a minor group of patients, so less than 10%, had an M2 occlusion, and that was usually the indication to use a SOFIA 5 French catheter, or if it's a distal M1. You see that in 3 cases, the SOFIA Plus was replaced by SOFIA 5 French because it was not possible to reach the occlusion.
So that's 1%.
Yeah, that
Okay.
was very low.
Yeah.
So in the majority of cases, we were able to bring the catheter up to the occlusion site. But as you also can see here, that in a little bit less than 20% we used stent retrievers. And usually this was because of the fact that the aspiration was, let's say, not completely successful. So it was a bailout idea or strategy. If we go to the endpoints, then you see that, and here the primary endpoint of this registry, because when we designed the registry, that was in 2017, we thought we should still look for a clinical endpoint. That's why we used MRS CO2 at 90 days, and this was achieved in almost 64% of the cases. And then, of course, we looked at different secondary endpoints, like the recanalization rates after first-line aspiration, and then, of course, at the end of the procedure, and of course, the different procedure times. Very important, I think, is if we talk about different recanalization techniques or thrombectomy techniques, is to look at the first pass effect, which I think is a really good measurement to compare different techniques. And here you see that we were able to achieve a first pass effect with the Sophia 6 French, so Sophia Plus in 48%, and with the 5 French in 52%. It was even a little bit higher, but probably it was related to the fact that we used the 5 French more in distal locations, so distal M1 or proximal M2, and probably the length of the thrombus, which was also measured, was a little bit shorter compared to the more proximally located occlusions.
This is almost twice the first pass effect of the original first pass paper, which is quite impressive actually.
Yeah, so we also published when we started with the Sophia Plus, we published a retrospective data set. This was also a multi-center study, and it was actually very interesting that we already achieved very similar results, which are now confirmed by this GCP trial.
Yeah. And I think it's a different animal if you have very strict core lab readers who are not involved in the treatment and they want to find something.
Yes.
Then I think it's even a higher bar, but still very impressive.
Yeah, and if you compare these numbers to other registries, so this is, for example, the one from Mr. Clean. They in this registry they also used Sophia catheters, but also other aspiration catheters. You see that here they were able to achieve a first pass reperfusion in 54% of the cases, but it's a mixture of all different occlusion locations. And here's another one from Stryker. This is the assists registry, and here the rate of first pass effect was a little bit lower, but I would say more or less the number which we observed is in the same range like other registries. If we go to the secondary endpoint of the recanalization rate at the end of the procedure, so this is the combining technique of using a stent retriever in 19% of the cases. You see that these recanalization rates are even higher within a procedure time of less than 40 minutes. And there was actually a nice drop of the NIH stroke scale at 24 hours from 14 to 4 at median. And here you see different safety endpoints, which I would say are more or less comparable to other registries. But very important, there was no device-related adverse event. So regarding the use of Sophia 5 French and Sophia Plus. Okay, so I have one case I'd like to show you, if this is okay. So that's a 78 years female patient. She presented with an NIH of 18 and a symptom onset within 3 hours. You see that this patient had an proximal M1 occlusion. So here you see the navigation of the Sophia Plus with the help of a microcatheter, but there was no need to cross the occlusion. So after placement at the level of the occlusion, we of course applied aspiration for 1 or 2 minutes, and then in this case we retrieved the aspiration catheter completely, and this was the result immediately afterwards. And we also looked, and here we were able to achieve a TQ3 result, but what is interesting in this case, so this was the clot which was aspirated. You see it's an almost complete white clot with a red nose. So this is, I do not know if you can see my mouse pointer, but this is the proximal part of the clot. And usually what we know from different publications, usually these white clots are really difficult sometimes to retrieve by using a stent retriever, or sometimes also by using an aspiration catheter, but here it was actually a very short procedure. Yeah, so in conclusion, Sesame is the first GCP study using Sophia and Sophia Plus, and we were able to show that these catheters are highly effective and safe tools for direct aspiration. in the treatment of acute ischemic stroke in the anterior circulation, but you can also use it, of course, in the posterior circulation. And these findings combined with other positive outcomes, and you will talk later on about another study, I think support the application of these catheters in the treatment of large vessel occlusions.
Yeah. Excellent. Yeah, thank you. I think that's great data, specifically because of the high quality of the adjudication of the events, of the imaging and everything, and it's very imaging focused as all of our studies. I have a few questions. So I think it was 63% good outcome, right?
Mm-hmm.
And what do you think was the explanation for the not good outcome in those patients? Because the inclusion criteria, you didn't show them, but we know that it's rather small core patients. Were they too late, too old, or?
Well, this is a good question. So basically, the inclusion criteria we focused on good patients at that time. So MRS is 0 to 1 and a time window within 6 hours. But even in this time window, because of, for example, poor collaterals, etc., even if you perform successful recanalization, you still have a number of patients which have a good recanalization rate, but still, let's say, not a sufficient MRS score at 90 days. So there are different reasons for this. We didn't look at this at the moment, but this would be, of course, something to focus in the future.
What was the rate of IV TPA on top?
The rate of IV TPA was a little bit higher than 40%.
Okay, that's interesting. Yeah, because if you look at the rate of good outcome, is even slightly better than Swift Direct, for instance, which seems to be a very high standard already. So more than 60% good outcome is really impressive. Is this something we should expect? Because we are going to talk about the ETIS registry, and the German stroke registry has something like 40% good outcome. Is this because of a highly selected patient population, or why are you so good?
I think that this is not the reason that we are so good. No, the reason is probably that this is not a real world population because it was highly selected. This is, of course, a drawback of this registry. But again, at that time, when we designed the study, it was still the idea to look at, let's call it, good patients, but. Now, if we, of course, look to real-world population registries like the ones I showed with the first pass recanalization rate, so here the rate of MRS 0 to 2 after 90 days is significantly lower because they included almost all patients. And this is usually the 60+%. This is something what you should not expect from your own data, but if you focus, of course, on patients with a low MRS at the beginning in a very short time window, then you can expect these results.
You reached approximately 90% reperfusion rate at the end of the procedure. So what were the reasons for the last 10%? Is there something we can improve to get the final step to the 100% reperfusion?
I don't think so that this is possible because you have, of course, tissue which is gone before you start with your thrombectomy, and therefore there might be territories which have a low perfusion, and even if you recanalize the whole large vessel, there are, of course, a lot of tiny branches which are not visible by angiographic means, and this is something what we at the moment cannot really treat. Maybe in the near future there is an option to give some add-ons like certain medication afterwards, lysis, whatever it is, in order to improve this microcirculation. But I think there is always a certain proportion of patients where you are not able to achieve a TK3 result, even if you recanalize the vessel occlusion location.
Yeah, this was the preparation for a much more ugly question, because there is a trend towards even larger bore catheters. 6 French was already crazy at that time when we started using it, and now we are going even bigger than that. Do you think this is necessary in the light of these results?
So you are right. So I think for M1 we are with a 6 French catheter we are able to achieve really good results with a high recanalization rate. I think the problem is more the carotid T occlusions, where the number here was low. It was less than 20% of the cases, but in these specific location, I think there is a chance of improve the first pass effect. And this is, I think, this is probably one location for the large bore catheters where probably there might be a higher chance of achieving a first pass effect compared to the 6 French catheters. And I think in the near future we will have the opportunity to use this 8 French super large catheters, and hopefully we are able to show even better results in this specific location.
Yeah, thank you very much, Marcus. And I think it's a very important message to our viewers that we are not at the end of the road. And even if we already achieve a relatively high level of good results, it's not the end. So we are further working on it. And yeah, thanks again and congratulations for this effort that you led. Thanks, Marcus.
Thank you, Jens.
Okay, our next speaker is from France, Foch Hospital, and he is a lot of things. He is the director of the stroke service of the Foch Hospital, and he's also coordinator of the ETIS registry. And this is what we will hear now. And I think it's exactly the other side of the spectrum. So on one hand, we had a highly standardized study that was very much focused on standardized image patient enrollment based on imaging and clinical factors. And then we have, on the other side of the spectrum, the ETIS registry, and we will learn much more about it now. Bertrand, welcome. It's a great pleasure to having you here in person as the coordinator of this registry. Please.
Good morning, and good morning, everyone. Yeah, it's my pleasure to share our experience in France about using aspiration catheter Sophia and Sophia Plus. Please see my disclosures. What I want to explain is we have a network in France. It's a bit particular because we collect all of the endovascular procedures with a high level of completeness of the data. So it's a prospective observational multicentric trial. And today I will present you our data about Sophia use. Around 890 patients was treated by Sophia or Sophia Plus. And it was, of course, large vessel occlusion patients with a follow-up at 3 months. And we collect angiographic and outcomes, clinical outcome, and of course safety endpoints. But the originality is we collect all of the patients. So there is no bias. I mean, all patients treated in France, quite whole, since 2017, were included in the ETIS registry and focus on the Sophia and Sophia Plus used today. It's of course national perspective. There is around to date 37 centers in France for this study. There is 26 centers, and it's a very huge tool for publication when we start now. There is 3 main goals of our registry. First is why I'm here today, is just to give you some insight in terms of efficacy and safety on the Sophia and Sophia Plus devices. But we use our network for assessment of practice in terms of metrics for each centers, small, large, private, public. And again, it's an effective tool for academic research. For example, and I think it's very important for neurologists, is to collect the metrics. So we did it for each center in France. So you have the median in national fashion, and for each center you have all of the metrics before the admission and after the admission. So you already heard, and in terms of efficacy of thrombectomy device, and especially for SOFIA and SOFIA Plus, we agree it's very effective, but we have to bring the right patient, the right time very quickly, so we have to monitor the metrics we impose. In terms of SOFIA use in France, France is very, very user in terms of SOFIA, because most patients was started with SOFIA. Around 61% of cases start with SOFIA alone or in combined with stent retriever. So we focus about 890 patients treated by SOFIA alone, and quite the same with SOFIA and stent retriever. And
sorry to interrupt, because I think this is very important for our conversation. So almost 2/3 of all patients in France are treated with a single type of catheter. This is correct.
Alone with SOFIA or in combination with a stent retriever, yes, but with SOFIA.
That's I think very special. Yeah, it seems to be very widely accepted amongst the colleagues. Okay, just to make sure that it's understood.
Yeah, sure. No, it's the right point, because operators in France are very confident with this kind of device. Yeah. If we focus on these groups, I mean, in terms of occlusion site, it was very, usual, mainly M1 occlusion, 45. If we look at, sorry, because this slide is not so easy to read, but we compare SOFIA alone, we compare combined stent retriever with SOFIA, and after that, when it doesn't work, the operator used to change, and when we start with SOFIA, they change for combined approach. When you start with combined approach first, it's mixed between aspirations alone, stent, very few cases, or combined also. And as you can see, we used to employ additional treatment in terms of stenting or using fibrinolysis during the procedure. In terms of, as you see, 30%, 28%. Our purpose was safety and efficacy. So first, safety. In terms of complications, the rate was very similar that we published and other group published before, around 6 to 7% in terms of embolism in new territory, perforation or dissection. There is no difference between SOFIA or SOFIA Plus stent retriever.
So the perforation, is it SOFIA related or any device related? So it's not specific, right?
It's not so easy to answer the question, because when you use combined approach, sometimes it's difficult to know exactly it's a stent or, so we cannot be sure that it's because of SOFIA or because of using a stent retriever also. In terms of hemorrhage, symptomatic hemorrhage, so the rate is a little bit higher in the combined approach, but don't forget that this population is more severe, more proximal occlusion also, so I think there is no main message on that. In terms of delay to access to the clot, the delay is very short with SOFIA, around 15 minutes. In terms of delay, it's between the arterial puncture to the clot contact. So when we monitor this delay, we report 15 with SOFIA, a little bit longer with combined approach. And the third group is a mix of aspiration alone or combined without SOFIA. That means that also if you're using aspiration first, the time is shorter with SOFIA.
Very similar to the COMPASS study where they had exactly the same observation. It's just quicker. Yeah.
It's because, don't forget, during the night or using aspiration catheter, and especially SOFIA or SOFIA Plus, it's very easy. Because you don't have, I am neurologist, no operators, but when we discuss, and it's very easy because you don't need extra hands. It's in terms of navigability, trackability, it's a very effective device, so it's explained why the delay is shorter in terms of arterial puncture to clot contact time. When I look at when we look at the angiographic efficacy, again we can start here, but now the TK2B3 around 90%. Don't forget in 2015, the first randomized control trial on thrombectomy, this rate was 71. So it's impressive to see the increase of 2B3 rate at the end of the of the procedure. But again, now our proposal is not 2B3 because 2B it's only more than 50% of reperfusion. So we need to focus on 2C3 endpoint and first pass because we know that it's directly linked to the good outcome. There is no main difference in terms of first pass effect between SOFIA 26, SOFIA plus stent 27, and the rate of TK2C3 is quite the same, around 50%, and the rate of TK 2C and 3 quite the same, around 69, 64. It's very impressive because it increased a lot since the start of thrombectomy. If you look at a little bit more precisely in terms of occlusion site, you see that when the occlusion is more proximal, when the clot burden is higher, the combined approach seems to be better. It has been already published from ASTER-2 trial, but there is other publication on that topics suggesting that operators should use combined approach for more proximal or higher clot burden, as we saw here in this study. And if we just try to have a look on the strategy in France from 2017 to now, to date, as you see here, first, aspiration in France was very, very higher. It was very particular in France. It's why we start ASTER trial also, because operators use to employ aspiration first. But now the trend is to be quite similar between aspiration and aspiration plus stent retriever in first line approach. And you see using stent retriever alone is very rare in France to date. A new message, it's about the evolution of first pass effect. You see 2015 and to date, 2022, the first pass effect increased a lot. And even, as I already told you that the rate of TK2B3, 71, and now quite to 90. So I think 90, it's a graal. There is, so the question now is to improve TK2C, to improve first pass effect, to use post-recanalization adjunctive treatment. And if we look at the progression of the rate of TK2B3 with contact aspiration, we saw an increase of the performance of this approach from the beginning.
Quick question to this slide. We see that, as you said, it was an increase to 2018, and then it's a plateau on a very high level, because how do you improve from 90%? But what I see here is also that the confidence interval is increasing. Is there more heterogeneity? So there are a separation of the superstar centers in France and some maybe less well organized?
No, it's a good question. Again, our data are very broad in terms of type of centers. So there is, I'm not sure that it's only due to the experience of the operator, of course, but we include each year new centers. Okay. So the experience in this center are quite low at the beginning. So I don't know exactly. I think we get a plateau now. Yeah, because it's extremely hard to improve from 90%. So as we all know, so the last % require the most effort. Yeah. But again, for the neurologist, the message is, okay, thrombectomy is effective, and with SOFIA, SOFIA Plus, the rate is very, very impressive, but we have to get our patient very quickly, because we know there is a time-sensitive efficacy, so it's very, very important to short. And again, to date, the delay is very long. Yeah. For example, in France, between the admission time and the start of the procedure, it takes around 100 minutes 100 minutes between admission and starting the procedure. So we can improve the device and everything. It's important. And with, as we saw with the SOFIA Plus, we get very, very high rate of reperfusion, but we need to get more time for the outcome. And my last slide was just to focus on SOFIA in France, as we discussed. I was very impressed as I work on this topic about the use of SOFIA and SOFIA Plus in France. As you can see here, in 2022, it was around 65% starting with SOFIA alone or with SOFIA Plus stent retriever in France. So our operators are very, very confident with this kind of device.
Yeah, excellent. So thank you. I think it's a very interesting insight into the real clinical practice. And again, I'm really impressed with the numbers here and with the widespread use of SOFIA. I have a few questions. So number one, what was also interesting was this slide about the time course of the different approaches. You said combined. It's I think one earlier. Yes, this one. That the combined approach also kind of, okay, the differences are very small, 51 to 47%. And you mentioned that most likely the combined approach makes most sense for the most difficult of occlusions, the proximal ones. But if you look at the practice in each center, and I think I saw a slide from another presentation on the ETIS registry, there's quite a clear practice pattern. So some centers use stent retriever only, and some centers use combined approach in the majority of the cases. Do you think that this changed? So do you have maybe an idea about, because what we see here, we always assume that the practice in each center is very similar, but in fact there are centers who are fully on stent retriever only. That's what they do, and they will never change it. Do you have any idea on this?
Well, in France, starting with stent retriever only is very rare.
Okay.
There is no centers in France starting, very, very, very rare. So most of the time they use aspiration first or combined approach. And most of the time, if the clot is very proximal in terms of ICA terminus, for example, they use combined approach. It's a longer clot, they use combined approach. Yep. There is no definitive answer on that because we try to give some insight from MASTER-2 trial, and there is a vector trial will be published soon, focused on combined approach. But most of the time, if the clot burden is very higher, they use combined approach, and it's why, as you saw here, you can see here the rate of combined approach increase. But as you know, it takes more time, a little bit more complicated, and what it's 2 EM and using a lot of devices, sometimes it's a little bit complicated. But now it's quite a plateau between the two approaches.
I see. And I think one of the beauties of the ETIS registry is that you have, let's say, 4,000 or 7,000 patients in 2022, 23 alone. And I think this gives us a very good information about the practice pattern. And
I think it's a point. It's an important point because if one of our goals is to evaluate new device, and I think it's very important to use contemporary data and not historical data. When I saw some performance global analysis, so using data from 2015, I think we saw the rate of improvement in terms of TK2B3 to first pass effect. So we need to use very recent data, and what we did in this work.
Yeah, and a particularity in France is the usage of MRI as an imaging modality in many centers. So I think in the rest of the world it's not done that way. Do you think this influences the practice of thrombectomies, selection of materials?
No, in terms of materials, I don't think so. In terms of using IV fibrinolysis, I think maybe, because we had a lot of information with MRI at baseline, especially in terms of positive lesion in flare, and sometimes neurologists prefer to avoid fibrinolysis I think we have to be very careful about that. And the Germany group published a paper very interesting because it shows that there is a decrease of using TPA before endovascular thrombectomy and now. So maybe because neurology thinks that, okay, thrombectomy is so effective, so I prefer do not take too much risk. I think it's an error, and we need to use TPA, especially in the very early time window.
Yeah, and why do you think?
Because I mean, now we treat more severe patients with larger volume. I will talk in the randomized control trial, last and tension and Tesla and everything. So, and with late window. So, when neurologists have one contraindication, says before there is no alternative. Before there is only thrombolysis. So we push a little bit the indication. Now we have the thrombectomy. So sometimes we prefer directly go to the thrombectomy. It's a mistake. We need to use both.
Yeah. So there's definitely an added therapy effect, even if it's small, and most likely it's as you mentioned. There's this publication on 2 hours 15 minutes. Like it's replicating the IV TPA studies. That its IV TPA effect seems more time dependent than thrombectomy effect, but yeah, it's still there. So 100% agree with that, and so I think that was my major point here. So again, congratulations for this effort. Thanks, and I think it's a lot of work, and it gives us a glimpse into what's going on, and we can learn a lot from it. And thank you.
Thanks a lot, Jens.
Okay, and then we go. I think that's a very nice transition as well to the more peripheral occlusions, where we have a higher effect, most likely from IV TPA. And the question is, do we need thrombectomy there? And it's my special pleasure to introduce Serdar Gayik. He's a professor of neuroradiology in Istanbul, and he will talk about distal occlusion and what he does with them.
Oh, thank you for the introduction. Yes, it's good to see you and be here. Hello everyone. We are talking from ESO TV studio today, and the recent topic after 2 wonderful talks will be distal medium vessel occlusions. Can we go on with the slides, please?
Probably you need to select them yourself.
So, coming back to the distal medium vessel occlusions, why we are talking today about the MIVOs is the main reason is the incidence. 25 to 40% of the occlusions of the acute ischemic stroke is due to medium vessel occlusions, and if we think about the journey of the mechanical thrombectomy, the 5 big papers published in 2015, they are all related with the large vessel occlusions. And then the efficacy over the medical treatment was proven, but we have learned a lot starting from that day about the symptomatology, scales of the symptoms, and then imaging parameters, going advanced imaging parameters with the large vessel occlusions. But those studies did not include most of the case scenarios that we are dealing today, is like tandems, wake-up strokes, but the majority is, including the posterior stroke, but the majority is distal medium vessel occlusions. So when we come to the distal medium vessel occlusion, symptomatology is very variable. Why? The arterial territory is variable, like anterior circulation or middle cerebral arterial circulation, or the posterior circulation of the MIVOs are very variable in terms of the clinical symptomatology and the treatment techniques. When we go look at the data, we show that 50% of benefit is proven with the alteplase. Just to be secure, it's not, mechanical thrombectomy is not still yet proven to the distal vessels, but today we know that there are lots of studies ongoing, and then we know that there are published case series, and most of the world is dealing with the distal thrombectomy. Likewise, the LVOs, first pass effect is very important at the distal medium vessel occlusion treatment as well. Why? First pass is so critical because if we don't have first pass, distal embolization gets 4 times more, and then the embolization into a new territory will be 3 times more if you don't have any first pass recanalization while doing your mechanical thrombectomy. So what they say is best clinical outcome correlates with first pass, but is it really true? I don't know. Maybe the worst clinical outcome correlates well with the distal embolization or embolization into a new territory, but it's both are the same in the direction. And then when we come to the ERIC retrieval device, what it provides to us for the distal thrombectomy in terms of technique, this is compared to the first generation stent retrievers, those are cylindrical in shape. This one has a different style. It is consisted of interlinked, independently turning cages. Those cages has, at the lateral side, large openings to get integrated with the clots. Likewise, the first generation stent retriever does. Plus, those cages has the possibility of capturing the clot inside the cages. And then, in this way, there are spaces in between cages that the thrombus can drop inside the cages as well. So you have 3 different possible way of interaction. So we can add the case pictures. We can see that clot can be captured inside the cage or in between the cages or integrated with the cages. How we achieve that one is, when we deploy a stent retriever through a thrombus, we don't expect the thrombus get down inside by itself, right? We have to force it one way. The stent retriever applies an outward radial force, and then they get integrated. And this one, we have something to get drop inside the spaces between the cages. It is the aspiration catheter. When you advance over the stent retriever, then you shave the clot between the stent retriever and the wall, and then the spaces between the cages would be the dropping zone.
I think, may I ask a question? So the thing with the more distal occlusion is that you have more tortuous vessel in the periphery, and ideally we want to grab the clot as good as it gets, and at the same time to have as little friction at the vessel in order to not push too much traction force. Could this be an explanation?
Yes, that's 100% true. But if we don't, I mean, there are papers that proves that if you use combined technique, I mean, the proximal aspiration combined with the stent retriever, then you can shave the clot as well. Yep. The efficacy is much better than using single stent retriever or single aspiration. Combined is, likewise the LVO, it's much better.
Okay.
And here's a case how it works. This one is large vessel and 1 occlusion, left and 1 occlusion, and then stent retriever is deployed through the M2. Here's the aspiration catheter advanced over the ERIC retrieval device. So it's kind of shaving the thrombus between the wall and the stent retriever, and then that's the first pass result achieved ticket 3 in this particular case.
Okay, I think that's very important to see how the Sophia goes.
Advance over the stent retriever. Otherwise, those spaces in between the cages, they're not useful. They're not functioning if you retrieve back. So, looking to the details, ERIC retrieval device at the cross section has a star-like shape. Compared to the conventional first generation, they're aligned 360 degrees with the vessel wall itself, but this one has like star shape and the 5 points touching to the vessel wall, and then the rest is not touching to the wall, and the outward spaces are getting working as integration, getting clot inside the cage. So cages are independently rotating. What it means, they can take the shape of the curvatures easily, and as said before, there is soft outward radial force, then it target to not to stretch the vessel. Another case example here, M2 occlusion, single branch. After the M1 bifurcation, there's a sharp turn here, very sharp angle, and then another turn here. It's kind of Z-shaped vessel. I don't understand how that thrombus went over that one, not their straightforward vessel, but things may happen, we know. And then look at this one, again, M1, and it's sharp turn, another sharp turn. This is the advantage of the independently turning curves, so they can take the shape of the curvatures much better than conventional cylindric type, because there's a unique body. So if you deploy it towards the curvature, they're not going to meant to take the shape of the curvature, but the vessel will be elongated or change the angle, which is very risky for the small perforators coming out of the vessel that we don't know. It's stretching, not only stretching, changing the angle even though is a risk factor for having subarachnoid hemorrhage.
So if we look at this branch, we are below 2 millimeters, and you use the ERIC 4x20.
It is 4x20. Let's look at after the recanalization. That's one of the advantages. Here we got the result, captured thrombus in the 3 of the cages, and then when we look at it, now it was pseudo narrowing or pseudo reduced caliber. Let's say this branch is not so tiny itself.
No.
Otherwise, we didn't talk about, because we have limited time, we didn't talk about the NH scale of this patient. It will not be high NH for this patient. But the good part of the stent reaver, you can use 17 microcatheter. It's not, I'm not sure that it's ready to use in all of the countries regarding the logistics, but here in our country we can select, either you can select 3 millimeter. After you a little bit give contrast medium, you can understand the diameter of the vessel, and then you can select your stent reaver size with the same catheter. That's another advantage from technical point of view. So our single center data regarding 50 patients, mostly those were M1 and M2 occlusions. NHS was mean 14, and the aspects were 9 with the IQR 5 to 10. Our first pass results that we had achieved with the ERIC retrieval device was TICI-3, 32%, 2C, 16%, having in the first pass excellent recanalization rate of 48, and then if we add on 2B 67, it will be 58 in the first pass. I'm not talking about 2B 50 anymore. I don't think that it's valid from now on, that 2B 50 from success story. And then there are a couple of measures for the thrombectomy series. First pass rate, last pass rate with the same device, and then the rescue need for rescue. Our final recanalization rate with the mean 2.2 pass was 44% TICI-3, and then TICI-2C more than 70, and then the TICI-2B over 90%. The remarkable part of this procedures was 34 minutes mean procedure time. It was short, and most remarkable, I would say, the complications and adverse event part, because we didn't observe any device-related serious adverse event, but our subarachnoid hemorrhage rate was 4%. Published series are mostly above this. Why we achieved in this one? We have limitation, of course, single center plus 50 is not enough number, let's say, talking about a big series, but still having this percentage of low rate of subarachnoid hemorrhage, to our opinion, it is because of the conformability. Number one, LINX takes the shape of the curvature, and then number two, they don't touch the vessel at 360 degrees. They have only star-like limited touching point, maybe. Of course, it's hypothetically, let's say, it's occurring going for less stretching, less screwing of the vessel. It may end up like this.
Okay, cool. Yeah, congratulations for this series. 50 cases distal with the ERIC. That's quite impressive. So I think one question is, where does, maybe the easier part is, where does distal stop? Is there any place where we say, I don't go there?
Well, anatomically, I believe that there's nowhere that we cannot go at the moment anatomically, but we have to, that's a good question actually, we have to combine with the symptomatology and then the pre-op imaging. If you have an infarct and if you don't have any viable tissue to go for rescue, and then whatever you do, you're taking a risk.
Yes.
And we want to help patient. It's not our privilege to go M4, but we can. Can we? Yes, we can.
Yeah.
But if it is where to go, yes, we can.
I think the ERIC is approved to 1.5 millimeter vessel or something. So maybe we don't want to talk about what you can do out of the instructions for use, but theoretically you could.
Oh yes.
To do that. Yeah. And the other question is, where does distal start, or does it matter?
Oh yes, that's another. But you know, I would like to ask this question to you. Where does it start? Because you're more senior and more elected with this issue. Where does it start?
Yeah, I think it's. I would consider M2 to still be part of proximal. And what is M2? I would really go for the Fisher classification, where it's it's strictly geometrical. So as long as it's in the lower part of the Sylvian fissure, I would always consider this to be proximal. And so your case was on threshold between proximal and distal, and then more distal. So Sylvian point M2, M3. Then it's really and it's also getting more difficult. And
our case was not typically having a typical anatomical bifurcation. It was a single branch. So one of the discussion is, if there's a single branch, we take it as distal.
I think essentially it's about the volume of the brain that determines the volume of the vessel, that the flow essentially, and then with this the diameter.
I totally agree. And then it comes to the pre-op imaging facility. If you do a pre-op imaging that you can calculate the volume, then you can go on. I mean, you can decide, you can say something different, or if you go for plain CT that you cannot calculate the volume, then you can say something different. By the way, another discussion would be where the thrombus is. I mean, if it is occluded distal, let's say, at the junction of M2, M3, but you see stop point of the angio proximal M2, because it doesn't go to the thrombus point. So how come you rate it as M2 or M3? There are lots of concerning issue with the saying M2, M3. But M3 is definitely M3, or M4 is definitely M4, or A2, A3. There's a certain, and there's a concern about the M2. Distal M2 is a
distal
medium,
dominant M2. So I think that's really a difficult discussion. But I think it doesn't make a lot of sense anatomically, but it makes a lot of sense in decision making, because people will start saying there is no evidence for that. But the threshold in the studies, so for instance Hermes analysis and so on, was quite blurry. And there is a sub-analysis of Hermes when they said, so they analyzed M2s, and there was also therapy effect in M2s, but what exactly was the M2? So I think
there are high NIH M3s as well.
Yeah.
Would you go for that? Yes, of course, because high NIH.
You could even say NIH is not a good tool for measuring.
I don't want to dive in that.
So,
but in the beginning, what we say, I mean, symptomatology, scaling for the symptomatology, that's all we learned from the LVO, not from the DVO. But today, almost 1/3 of the thrombectomies or 1/3 of the acute ischemic stroke is the MIVOS. So maybe we have to go for another anatomical scale, another clinical scale, and then another imaging algorithm for the MIVOS independently. And then when we say MIVOS, PCA MIVOS is not equivalent of the ACA or the MCA MIVOS, even though MCA may be divided into superior or the inferior.
Yeah, and even let's say you have the same the same symptoms, you risk hemianopia, and you have a 87-year-old who lives a wonderful life, but
Yes.
you wouldn't risk going there most likely. But if you have the famous 52-year-old lorry driver, you probably
yes.
would do it. So there are so many factors, and I think in the end we
Definitely.
need to have clinical judgment, but at the same time a bit more standardized guidance, as you mentioned, maybe different scales, something like that would help a lot.
And then at the end, still with the any kind of device, let me say today, every case study is very good, but still we have the 50% of the success rate for the first pass effect. And almost same with the other device. Do we agree on that? Well, is there a device that we can provide, let's say 70% or
Yeah.
exceeding above the first pass rate? No, still not yet. Today we are stuck in around the 50s with any kind of mechanical thrombectomy device. But the good part is we are coming around the 100% within the total
Yeah.
final reconstruction, let's
Yeah.
say.
Yeah, definitely. So we have different aspects. So the technical, procedural improvement, exercise, clinical judgment, all this. And yeah, thank you for sharing your experience with distal usage of ERIC. So we are using it for distal occlusions as well, actually. But still, I learned a lot. Thanks.
Thanks for the invitation.
Thank
yes.
you,
Good
Sela.
to see you.
Was a great pleasure. And yeah, thank you very much for your patience and for listening to us. And yes, so it's now my role to conclude this TV session. And it was a great pleasure for me having all this spectrum from measuring the effectiveness of SOFIA in a very standardized fashion with external committees with a very good first pass reperfusion rate, very good final outcome. Then the overall experience in France with the, yeah, let's say 2/3 of the cases almost are done with the SOFIA catheter, which impresses me a lot. Very good outcomes, very good registry where we can learn a lot from. And then finally the final frontier, the distal occlusion, where we made a lot of progress in recent years as well, and we will learn a lot in the very near future, maybe next year at ESOC, with the distal studies being presented. Thank you very much, and thanks again for supporting this session to Microvention, and have a good day. Thank you very much.
Hi, welcome back. I'm still Elsa Sanset, a stroke neurologist from Oslo, and we will now spend some time discussing the results we just heard in the large clinical trials session. With me now, I still have Robin Lemmens, but we are also joined by Ellis, Klaus, and Carlos from the Netherlands, Denmark, and Barcelona. So let's start. Robin, I mean, you chaired the session. Are you happy?
I'm very happy. Well, I think what strikes me all the time when they present these results for the large clinical trials, how much work this must have been for most of these PIs and sub-investigators and the whole team involved. Several trials were presented that were initiated many years ago with a lot of hurdles, barriers to complete, and then in the end they come and show these results. And I think it's just amazing that so many of them have the courage and the persistence to complete the trials. This is actually separate from the results that were presented, but just to finalize these things over such a long period is just amazing, I think.
I think to summarize that in an 8-minute presentation, it's 10 years worth of work that you put into 8 minutes of where you present your results. So it's a big achievement for all the people who presented today. So, but Carlos, what were the highlights?
Well, it's really amazing. This first day of the large clinical trial session show us how we succeed to put all the spectrum of the stroke research in one session. So from the primary prevention with the polypill trial, also with the pre-hospital with the tactic trial, acute management with TASTE trial, and also the CHARM and the ActiSafe trial, the secondary stroke prevention convinced result, the ICH switch, and also the results of the clinical impact of hematoma expansion and thrombotic events in the Annexa I trial, and also rehabilitation. So the full spectrum is there. So the main highlight is that we are more and more in primary prevention. So stroke neurologists will take over this part of prevention, focus on stroke. It's a strategic position, I think, that we have here. And they succeed in Brazil to run this polypid trial. It's a pilot trial, it's a small trial, but they approach the primary prevention as the primary physicians, and also primary physicians to prevent the stroke using the riskometer, which is a very advanced way to monitor and control risk factors, and they reduce the number of the control of risk factors in this population. I think it's a good achievement. Tactics was really nice. I really love this proposal at a regional level. So how they improve the drip and ship process, and also the number of thrombectomies and reperfusion by 44%, and the door in, door out, which is the time method that is more difficult to improve.
I was also very much impressed by the virtual reality glasses they used for the training. It's such a nice.
It's a matter of training and also get engaged all these small hospitals, these POC hospitals in this network, and the result is that for one side, the door in, door out was improved, the door to needle time was improved, but the door to growing time was longer, which is something we need to check what is the problem here. Yes. So if you reduce the door in, door out, it's expected that the door to growing is going to be shorter. So because of the pre-notification of the hub. Yeah, what do you think about it?
Yeah, that was also a bit surprising, but this is actually my favorite part of the conference. You know, it's beginning, all the big trials being presented, and we now have time to discuss them. And I guess for me it was also CHARM, which was a very big effort, as you say, Charlotte. People have been working on this since 2018, and initially it looked like the drug worked on edema evolvement, and then sadly after conducting the trial it was neutral. But I think it's very important that we see these trials, we follow them through, and it's amazing work from the primary investigators. And yeah, I also enjoyed the switch. Actually, now we see more things being evidence-based on the hepatoma side, we saw Enrich last time, and now we see Switch.
Yeah.
And maybe there's not a big benefit of hemicraniectomy, but at least now we know. Now we can approach the patients and families and lay out the data.
Yeah, and tell us also how important it is to select properly the endpoint for clinical trials. This shift analysis was positive. The shift analysis was the secondary endpoint, but they missed the primary endpoint roughly, because it's the ranking 0.4, I think. But they didn't find any benefit. How do you think it will impact guidelines in a way that this is not a clear positive trial? Of course, it's a neutral. They missed the primary endpoint, but I think the results are impactful, and it's unlikely to have a trial like this in the future.
Yeah, I think so too. That's of course a difference. I think with the ischemic stroke trials, I've also looked at the benefit of hemicraniectomy, but there were several trials going on at the same time. They pre-specified the meta-analysis, combining the data, and then they had the sample size to show this. So this is just one trial, but it's been done. I mean, it's been recruiting for over 10 years. So as you say, it's not likely that this endeavor will ever be done again. And so, of course, and he showed the meta-analysis, but of course the endpoints for the different trials were different, and the interventions were difficult. So that will not be in the meta-analysis to convince a guideline working group, I think. Depends a little bit of if a guideline working group would come up with the meta-analysis just focusing on this intervention, maybe there's something there. So what the guidelines will do, I don't know, but I think it helps to inform us in clinical practice. I think it will help us inform patients, as you mentioned, and relatives that, well, there is this potential option, and we can then state that it increases their risk. Or decreases their risk, to be in a very independent and non-preferable status, like modified ranking 5 or 6. And that this is something that can be considered. I think then in communication with relatives, mainly I would think, sometimes patients, but mainly relatives, explaining that and then getting hopefully a little bit of information how the patient would potentially look at that particular situation can assist us in making an optimal decision. It's not always, I think, that if there's overwhelming statistical significance that we can only conclude to do something. I think a lot of is being done in clinical practice without any evidence. At least there's evidence to support a good conversation, I think, with relatives, and that's important as well.
Yeah.
I think with the tactics and the polypill trial, there are also very good examples of having trials where you do research and implementation at the same time, which is in a way undervalued, or we do it too little.
It's exactly what we need. We have a lot of evidence out there, but we fail in implementing these strategies in real world.
Yeah, and also extrapolate our knowledge to more rural areas and try to improve stroke care over there, not only in Europe. I think it's very important.
But I like your point about how the session highlights different areas of research, prevention, acute care, hemorrhage, and also implementation. As you say, we have good treatments, and now we need to implement it also in places that are not close to a university hospital. One of my big take-homes was Peter Kelly's presentation of the colchicine drug, and of course Convince trial, and of course neuroprotection, anti-inflammatory drugs have long been evolving, and we have big hopes, and often trials are neutral or almost positive. So I'm curious, what do you think about the trial? Certainly there's room for maybe focusing on a large vessel disease, as he said in the end.
Yeah, I think it's a large trial. More than 3,000 patients were randomized so far, well conducted, multi-center, global trial. I think it's patient selection again. So it's not just take out those patients with atrial fibrillation or cardiovascular stroke, means non-cardiovascular strokes, but also the behavioral lacunas is different. So I think we need to implement bundle care into clinical trials, just not focus on anti-inflammatory effect. Maybe it's unbalanced in terms of the antiplatelet regimen, dual antiplatelet therapy or monotherapy, and also the level of control of blood pressure can be unbalanced, and all these issues, and also the structural type plays a role. in the recurrence rate and also the impact. But they include not only the recurrent stroke, but also myocardial infarction. So I don't know if you take it off from the equation. So myocardial infarction, sometimes myocardial infarction, especially in TA minor strokes, create more noise than adding value to the primary endpoint.
Yeah.
So we need to check that for the future. Yeah. But it's an enormous effort to have a trial like this, running by neurologists with a long-term follow-up, more than 3 years, I think 3 years follow-up. It's amazing, 34 a month follow-up.
Yeah, median. So
Median
many
follow-up.
patients were
Yeah.
in the trial for a very long
amazing.
period, which also makes it challenging to. And that, I think the longer a secondary prevention trial takes, of course, it becomes challenging as it relates to adherence to the treatment, follow-up of the outcomes. And so, we need that amount of time, right? And if it's an acute treatment, we typically look at 90 or 6 months, right? 90 days or 6 months. But for secondary stroke prevention, we have to have patients in the trial for a very long time, which create challenges as it relates to budget and adherence and recruiting of patient, trial fatigue and all these things. So, same is, I think, true for switch, but also took more than 9 years to recruit patients. I mean, you have to be very, as I mentioned before, persistent to be able to finish that, I think.
Absolutely. What about you, Alice? What were your...
Yeah, so I also wanted to mention that the TASTE trial, the tenecteplase trial, I was wondering what your take on this was. Do we need to ditch alteplase, or should we...
The thing is that when you add TASTE in the meta-analysis, it shows superiority of TNK over TPA, and there are some other, similar stuff that's going to be presented in the scientific session, focus on meta-analysis, novel meta-analysis and new analysis, incorporating the new evidence of tenecteplase over TPA, so showing superiority. So I think it will accelerate the transition to TNK that is needed. So we have this shortage suffering over the last months.
Are you using it?
No, we don't have it. It's because of the shortage.
Yes.
So just for myocardial infarction, but then nobody uses it because we have PCA. So.
But you would use it if...
We would.
Yeah.
We would, for sure. Easy, more convenient, just single bolus. So it theoretically, it will improve the indoor out times in community hospitals to accelerate the transfer to comprehensive stroke center. For sure is the future, is the reality in many other parts of the world. In the US, I think the transition is over. They just TNK, we're still TPA. But I think it was a long-awaited trial, TASTE. So it's not about advanced imaging. We know that now, so they suffer not only the COVID, but also other trials and also the shortage. But they finally did it. So not in the pre-specified sample size was 800 to 600, but still the results were not surprised. It's non-inferiority of TNK over TPA.
Of course. When they put all that work into make the trial selected by imaging and selecting patients with a large penumbra, you could speculate why wasn't it more positive. And I noticed that Dr. Tumala had the question about the lacuna infarct. I think it was meant as to make the point that the TPA, whether it's alteplase or tenecteplase, benefits
works
all subtypes.
All subtypes.
No, I think there's been a lot of great trials, and we see all the hurdles that people have gone through, and especially in the past 5 years, I would say there's been multiple hurdles in all of these trials. So we will now have a switch in our program here. So thank you, Carlos and Alice. Klaus, I would like to keep you here for a bit more. So. Yeah, no, that's okay. we have a nice replacement for you. So thank you very much, and enjoy
the conference.
Thank you.
Thank you.
Thank you for inviting us.
Thank you.
So Maren and Natalia, you stay. So we have discussed the trials, the highlights of the morning, I would say. There's lots more highlights to come. But now we will switch a bit, and we will focus on pre-hospital setting, I would say the main point of delivery of the patients to the hospital, and how do we find the stroke patients in the pre-hospital setting? How do we get patients from the pre-hospital, from their homes, to the right hospital at the right time, the right level of care at the right time? So we still have Klaus, and you have done a lot of work on this in Aarhus in Denmark. We have Maren from Oslo, and you worked in the ambulance when you were studying, so you have experience from the whole chain, and Natalia as well from Barcelona, Catalonia, and you, of course, you've done a lot of work on the RaceCat trial, so very glad to have you here. So who should we start with, Robin?
We will start, I think, with the Catalonia effort, I think.
Yeah. So you've done a lot of work on trying to select patients, and you have had a lot of focus on the large vessel occlusions. So can you tell us a bit about your experiences with RaceCat and the trials you have done in your region?
Yeah, okay, thank you. Yeah, we start implementing a pre-hospital scale to identify LVO patients. So first we start developing the RACE scale. There are other scales, and then we try to demonstrate that using this pre-hospital triage tool, we could identify patients to do a mothership model, but then RaceCat was not positive in this way, and we have think a lot about that. And we can finally conclude that probably it's not the same for everyone. It depends on many things, and what works for Catalonia is not the same than everywhere. So it's nice to be here again to talk about that, because we can share a lot of different experiences in different geographic realities. So with focusing on the RaceCat, I will say that if a patient is a candidate for IVTPA, then I think that we have to prioritize IVTPA in the local hospital as soon as possible. And if the patient, if you can suspect a hemorrhagic stroke, and then we need tools to suspect this in the ambulance, then it's better to attend this patient in the local hospital. But there are some patients that probably need to be directed to an endovascular center, so we need to continue selecting this patient, and it's also very different in the urban area and the rural area. So we have a lot of work to do, and now in Catalonia, we are trying to implement thrombectomy in local centers. This is the first thing that we did after the RaceCat. So we are doing thrombectomy in primary centers, and then we are trying to improve the RACE scale to identify hemorrhagic patients and distinguish from LVO. Yeah.
So I will then go on to Maren. Maren, you have your PhD on the mobile stroke unit, and you completed the PARANASP trial. Tell us a bit about how do you view the pre-hospital selection, and what do you think we should focus on?
I believe that we need to have a broader focus on the patient population, because stroke patients are not only LVO patients, it's the total population of stroke has lower NIHSS scores. We can see from the Norwegian National Registry that 50% of the stroke population has an NIHSS of 0 to 2. And I believe that we need to rig a pre-hospital system that enables us to reach out to all of these patients, and that all of these patients should be selected for early acute treatment. And then we need to look at the chain of survival from the first contact, because there are several levels of selection before you end up in a hospital. And the first part of that chain is the dispatch centers. And up to now there has been some research on dispatch for stroke, but I think we really need to increase focus on the dispatch centers and to enable them to start the selection. And then we need to ensure that we, with new technology, actually enables the paramedics to have all the information that is collected in the dispatch for their use in a clinical assessment. And then we need competence in the paramedic staff to find strokes beyond the LVO symptoms. And NIHSS, we explored that in the PARANASP trial in Oslo, and it has some strengths, but it definitely some weaknesses as well. And I believe now we need to look into the other symptoms from the posterior circulation strokes. We need to look for sex differences, and we need to rely on new technology, because we can build in algorithms in these tools. We can specify them for different patient groups, and I believe that that is the future for selection of patients.
And so do you, because we're familiar with the trial performed in Norway, of course, but do you know if there are, if that could be organized on a European level? Because the organization of dispatch and ambulances and ERs and all these services is pretty diverse. And so how do you see that on the European level? Because there's, of course, this initiative also by ESO focusing on stroke prevention all over Europe, the SAFE initiative. So do you think that something which is shown to be beneficial in Norway, for instance, can we implement that all over Europe, or how do you look at that?
I think first of all I want to thank ESO for now encouraging us to do a new pre-hospital management guideline, and we will go through all the literature available, and hopefully we will be able to make some more statements next year. But I think the systems are different, but are not that different. All countries has a dispatch center, at least European countries, and the dispatch is communicating with an ambulance service in some way. And then we need to develop tools for communication between these parts of the chain. And I think we need to focus more on competence, because paramedics, they can be trained, and we need to train them. And we need to train them for 2024. Not with paper sheets. We need to train them with virtual reality, and we need to go out there and communicate with them in a much closer level than we do today. Yeah.
And Klaus, what are your experiences from Aarhus?
Yeah, of course, we all would like to be able to distinguish the patient in the ambulance and say, this is hemorrhage, this is large vessel occlusion. But if anything, RaceCat and triage showed that maybe the most beneficial thing was just to get into a hospital, as the nearest hospital, as fast as possible. And maybe we could get, more bang for the buck if we kind of invested in stroke awareness, making patients call the dispatch system, and as Maren says, train the EMS persons, and that they have a tool to investigate them. And if it's RaceCat, or if it's RACE or another pre-hospital triage tool, it doesn't really matter. Our EMS persons, our ambulance personnel say that they like to have a tool to communicate with us. So sometimes they actually find it a bit intimidating calling the neurologist and try to explain these symptoms, but that and remember that the ambulance stroke is maybe 1% of all calls. So and then it's not a normal day situation for them. So to have them to have a tool for them to talk with us, that is a great value. Then I know there are people doing research of where you can have a camera in the ambulance. Actually, at my hometown, I don't know if maybe everyone knows this, but the dispatcher can actually make the caller send a link, and then they can press the link, and then they can, because everyone has a smartphone nowadays. So now they have eyes on the scene, and this can be done very easily. So I think maybe you're alluding to new tools and new systems. I think there's a lot of ground for us to improve patient care here. And then we can discuss, and I'd love to discuss, the intelligent direction of the patient. We really hoped that bypassing the primary stroke center and favorizing the comprehensive stroke center would benefit our patients. But we did the studies, and as evidence is now, it didn't. So now I think we should work on developing the primary stroke center so they can evaluate the patients quickly.
Yeah, probably our trials were not in favor of the direct transfer because the drippage ship is very well organized. And sometimes then you see, and I don't know, other experiences with a door-in, door-out time of more than 1 hour. In RaceCat it was only 70 minutes. So after RaceCat we have our experience is that times are getting worse after the trial. But yeah, of course, because when you are doing a trial, everyone is, they know, all the primary stroke centers, they know that they have to register all the times. So it's important to continue training all the system, and also to have a monitoring system. And this is the same for Europe. I mean, we're talking about if the recommendations can be the same.
Yeah.
Some of the recommendations are the same because everyone has to register all the times, and the pre-hospital time have also some different times that we have to monitoring and try to reduce.
Yeah.
So I think it's important to continue doing things out of the trials. Yeah.
I definitely agree.
Yeah.
We need pre-hospital quality indicators for stroke care, and we need them implemented.
Like door to needle, or
and symptom onset, pre-hospital cycle times. Yeah, and I totally agree with the video possibility, and I think that's for future research definitely, and more than just asymmetrical facial. I think there is more into video than that. So.
Yeah, typically those quality indicators are somewhat neglected. Everyone's focusing on door in, door out, door to needle, door to groin. And then when you talk about what's the onset to the needle, well, that's outside of our hospital. Within the hospital, we cannot do so much about that. But of course, these kind of programs are essential to identify what can be gained by doing these kind of initiatives, and not just saying, well, that's outside of our hands, it's within the community, that's not, we cannot change it. Well, actually, probably we can by doing all these interventions that you're mentioning now.
So we're getting to the end, and I think I want to spend the last couple of minutes to discuss. You say focusing a bit more, you're moving intervention to the primary hospitals, and Maren, you are moving CT out of the hospital, not only with an MSU, but placing CT strategic places where there is long transfer to the hospital, and that is how do we provide imaging in the best way. And Klaus, you have probably given this some thought as well.
Well, Klaus is putting MR machines into this.
Every street corner. No, I would be very interested in listening to what other people have seen with MSUs or the mobile stroke units. Of course, we all read the interesting article by the Houston group and how early treatment benefited. But of course, that was in a rural city where transportation times are short. But if the MSU is driving a very long time to get to the patient, dispatch is important. Do we send the MSU to the right person? I think as it is now, and with the geography in my region, the benefit of the MSU is probably not as big. I would guess, but of course it needs to be examined. But so how do you use the MSU in Oslo?
The MSU project is not running at the moment, okay. But I want to think out of the box, out of the MSU. I want to think how can we make the CT available for the stroke population. And I don't think we need to box it into a car. In some areas will be beneficial to have it in not a primary hospital, but like a out of office GP center, smaller facility. And we have a study going on in the mountain area of Norway, southern Norway, when this CT scanner is fully staffed and run by paramedics, and we train them to do the NIHSS to do the selection, and then we train them to do the actual, do the scan, and then all the interpretation and the communication around TPA or no TPA is done in collaboration with the on-call stroke physician in the local hospital with telestroke. And these kind of hubs of putting CTs out there, I think we need to look into that much in more detail, and not only think that pre-hospital CT has to be in a car. And with new technology, these CT scanners will be smaller. They will be cheaper. And they will, when we need to work together, ESO and the pre-hospital researchers, to make these available for the population.
So when I said we need scanners in every street corner, you actually took it serious.
Definitely. I think that we don't need a lot of infrastructure around these scanners. What you need is a simple non-contrast CT image, and you can do a lot of good care based on that. And we need then selection for patients whom to put into the scanner.
So it's like a mix between a mobile stroke unit and a drip and ship, no? It's like not a hospital, but a place where you can do a CT scan.
Yeah.
With telemedicine. So,
And we need to believe in training other healthcare professionals. I think neurologists don't need to be there to do all this work.
And maybe is it
we
useful
can train
also
them,
for
and
other...
we can do telestroke.
Maybe it can be used also for other, not only for stroke, for other emergencies.
I think for cost benefit, this analysis is very interesting, because between the strokes, then you can do ambulatory CT scanners for cancer patients, and you can reduce transportation time for critically ill patients, but they are living at home. And you can actually maybe increase quality of life as well, because nobody wants to stay in a bus for hours to get an ambulatory CT scan. So there are so many benefits out of this,
it's
and
a
you are
clever
actually
solution.
providing these CT scan that still is the core of acute stroke care. So
So, thank you. I think our time is up. Robin, do you want to summarize?
I think I'm very. It's very good to hear that you're working on this guideline. I think because pre-hospital care is really something that we have to invest in. We've been investing a lot in improving our acute treatments, and so we have to make sure that what we know is beneficial can be given to as many patients as possible. So, looking very much forward to next year, where you hopefully will be able to present those guidelines. Thank you.
Great. Thank you very much.
thank you.
Hello everybody and welcome to ESOC TV today on the first day of the 10th European Stroke Organisation Conference in Basel, and I'm delighted today to be joined by three people. One of my good colleagues from Glasgow, Alan Cameron, who's going to moderate this session with me today, and Charlotte Cordonnier, who all of you will know from Lille in France, and Deirdre Dippel, who you also all of you will know from Rotterdam in the Netherlands. So it's been a great day, Charlotte. I'll ask you first of all, was there anything that caught your attention from the large trials this morning or any other session?
Yes, so many exciting things that it's quite difficult to pick up one, but I think I was quite impressed by the trial presented by Sheila Martins about the polypill. I think what is really interesting that it was just the feasibility, 300 patients, but the concept to go on the primary care practitioner in a low income country shows you how to overcome the challenge of accessing to people very early on, before their stroke. And of course they talk about the polypill, so what do you put in it?
Absolutely.
So they put antiplatelet, statin and antihypertensive. So what could we add? What I like is that they add education, knowledge, the transfer of knowledge in this polypill. And it's probably something that will be extremely useful beyond the brain, really for the vascular health of people. And they're aiming for 8,000 patients. So that's huge. So I'm really eager to see how they will going to be able to do that, and probably because it was so exciting this morning, we will add colchicine, but also treatment to be able to tolerate colchicine.
One of my colleagues in Glasgow is very interested in the idea of treatment burden after stroke, and you know, as much as we have a lot to think about when a person comes in with a stroke to a stroke unit, the patient has 10 times as much to think about in terms of what's just happened to them, how they need to change, what treatments they need to undergo. And I think a polypill could really help simplify their care by, you know, making it easier for them to take the medication. So do you think it's something that we should even be thinking about in stroke units in Europe, in the US, in more developed systems?
For the very long term, it's probably easier to enhance adherence to treatment, even though I'm not sure it has been proven. But I think we're going also far away from the precision strategy, individualized treatment, individualized dosage. For example, for antihypertensive treatment, we know that everybody shouldn't take it at the same time. So from a population perspective, it's probably very good for the vascular burden, but from an individual perspective, I'm not so sure about the concept.
So. Absolutely.
Strike that balance. It was fascinating, the polypill. And Deirdre, yourself, any take-home highlights?
Yeah, I was impressed by the presentation of Peter Kelly on the CONVINCE trial. It was very near successful new treatment, a new paradigm, a new addition to the polypill, perhaps. And it still looks quite good, and I hope he will do a next trial, larger trial, maybe even more simple trial, and I'm convinced that it will be positive.
What did you think about the 20% of people who stopped the treatment?
Well, we were having a chat about that earlier, just over coffee, and wonder whether part of that might just have been the COVID pandemic, people unable to access some of their services, unable to get prescriptions.
Well, we know.
So how we disentangle that?
We know that for any preventive treatment, many people stop the drug, so you have to just count on that. No problem.
And also a third of women, 30% of women were enrolled. We really should better.
55%.
Should do better, huh?
That's true.
Absolutely. No, agreed.
But the concept of the colchicine treatment fits well with stroke unit treatment, a new treatment for all.
Yeah, absolutely. And one of the things we wanted to discuss was what's been termed stroke unit 2.0, and obviously we've had stroke units for a long time, but stroke care today in 2024 is vastly different to stroke care, 20 years ago when the evidence, or even longer when the evidence base first started to emerge. So what do you think a stroke unit today should look like in terms of who should be there and what facilities should it have?
I think we really should promote breaking the walls between the skills and expertise. For me, the next stroke unit is really the place where the expertise of technique for endovascular thing goes, but the expertise also for maybe more neuro ICU intensive monitoring of patient has a place. Of course, a place where the stroke specialist is, but it's not only medical and the usual allied healthcare practitioners that are extremely important today, but it's really opening up to more skills and expertise in the same place. At least this is where I see it.
One other idea, I think, if you look at the high-level interventions that can be done now, especially the thrombectomies, and perhaps other interventions will be coming up, you're in a primary stroke center with a stroke unit, you have to be embedded in a regional network, otherwise you won't do any good. But on the other hand, you have to realize that the bulk of the patients will be in a stroke unit and will not get thrombectomy. It's only 10%, I think, 20% maybe. So, and the effect of stroke unit is very large compared to no stroke unit treatment. So, if you don't give it to the thrombectomy patients and you don't give to all the other patients, then you're doing a very bad job. So you need to get the thrombectomy patients back and give them the proper treatment according to standards. And you have to certify your stroke unit. I think that's very important.
So it's quite surprising because we are in 2024, and in fact what we see is that the biggest fight that we have to go on is to be sure that all stroke patients have access to the first level of stroke unit that was validated in terms of evidence-based medicine 20 years ago, and we are still there. So it's difficult to talk about the 2.0 where we still have to fight, and just to have nurses and doctors in our own stroke unit today.
Have enough.
And I hear colleagues complaining that they don't have sufficient resources to set up their stroke unit, but that's where certification can help you. If you go to your board and say, we need to be certified, otherwise we're nowhere. So help us, give us more resources, more money, more people to get this going, and it will help our patients.
And one of the things I wondered after today's presentation of the SWIFT results, and thinking of the recent publication of the ENRICH study, which was presented some time ago for both treatments that suggest neurosurgeons might have a role in the care of people of ICH more than they do currently. So do you think neurosurgeons should they be on our ward rounds now, have a more prominent place within our stroke units?
Well, for the moment, the data we have on surgery on ICH, it shows that it remains probably a small proportion of patients. So I still underline the fact that ICH is a medical emergency first, and then in a few patients that we will be able to identify, yes, we need other expertise around the patient. You're talking about neurosurgeons. It could be neurointerventionalists in the near future, because there might be also different strategies to stop the expansion, because the surgery arrives at a time when you already lost the first window, which is stopping the expansion. So maybe there would be. You seem doubtful, but
I'm always doubtful. So.
We'll see in a few years time. But so bringing all expertise around, and maybe neurologists should do it.
Yeah, and the ENRICH trial had patients, a patient in a later time window, but there are trials going on at this moment where we directed the stereotactic treatment on the deep hemorrhages very early, and our pilot study looked very good. And we are now Nijmegen. Brian Klein is working on this trial. It's going well.
So it really means that all kind of patients all stroke patients have their place in the stroke unit. But with different approach, different expertise, very acute, very interventional for a small proportion of those patients. And as you correctly highlighted, we shouldn't forget the 80% of people
and do the basic
who
things
will
well.
not, who will not benefit from any, I would say, trendy or fancy intervention, but for whom the benefit of a specialist care is amazing.
And do you think we need to have any more involvement from our cardiology colleagues? We were wondering, we've seen some of the emerging benefits of PFO closure, and
I mean, it would make our ward rounds fun. A neurosurgeon, a cardiologist, there's so much alpha we can take.
That would make my day. And after this round, I take 1 week of holiday. But we said that it will stay forever on the web, so we couldn't say anything wrong. So of course, it's a great idea.
It is a great idea, absolutely. But it's definitely moving. I think as evidence-based, evolves, things will become even more multidisciplinary. And as you say, these interconnected areas of neurosurgery, stroke physicians, neurologists, intensivists are going to be more and more prevalent. But we do have to always remember the basics, don't we? Things like a poly pill, something so simple can have such a huge effect, and just doing basic things well, can have a huge effect. So thinking about tomorrow, is there anything you're particularly looking forward to? Have you had a chance to look at the program yet?
Tomorrow, blood pressure management around reperfusion treatment will be a topic in the ambulance, or before thrombolysis, after thrombectomy, it will be a topic.
So that
some more tenecte plays also, I think, in China.
There's bound to be.
Absolutely. Every day there's.
So the plenary session tomorrow does look good, and again, is it going to rain tomorrow? Has anybody checked? I haven't.
But we're going to run.
We are going to run
at 7 a.m.
Yep, at 7 a.m.
Everybody,
Correct. Yeah. Well, we're very much looking forward to that. Is there anything you're looking forward to, Alan?
I think the plethora of clinical trials. It's great to hear so many large trials that have been submitted, another session added to it. So early morning tomorrow, I think there's a clinical trial session, another at lunchtime, so we'll see some big data from that. And some more brain heart stuff is on the agenda, which I always look forward to. So great programme overall.
Yeah, indeed. Well, thank you very much.
Thank you.
All of you for joining us, and thank you everybody who's watching, and I hope you enjoy the rest of the conference.
Bye.
Bye-bye.
Welcome to ESOC TV. We are today here at ESOC, and at ESOC today the results of the tactics trial have been presented. This trial addressed the equity of care and the equity of reperfusion treatment throughout Australia. We got here Professor Delcourt and Professor Levi from the George Institute in Australia to ask about and cover some key aspects of the trial. We all know that equity of stroke care is a very important thing, and we all need to address this to reduce the burden of care. First of all, can you provide some details on the background of this trial?
Sure. Well, Australia is a very large geography, and we have the challenge of lots of smaller communities that are far-flung and many hundreds of kilometres sometimes from the Comprehensive Stroke Centre. So the thinking behind the trial was to think up an intervention that would support more effective access for those regional populations. About a third of Australia lives outside the capital cities, and the burden of stroke in regional Australia is actually higher than it is in the metropolitan regions. And the regional patients generally don't have access to advanced imaging. They have limited access to experts who can come and educate and train. So the idea behind tactics was to provide those smaller hospitals with the infrastructure and the education and training that they need and connect them better to their Comprehensive Stroke Centre.
Okay, so a great aim then. So what were the methods and what were the procedures put into practice in the trial to guarantee and to get to that aim?
Yeah, so we basically equipped the sites, so the small rural and regional sites, with advanced CT imaging, and then provided them with an education package which included multiple components, but one very useful component, which was a virtual reality training. And then we did, regular meetings with them, like for education, but also for audit and feedback all along the trial.
Okay, so moving towards the results, because we are all curious, because you are allowing more people to get treated and you are increasing, so the aim is to increase the equity of care. So what were the results? Can you cherry pick for us some of the key findings?
So one of the key things is that this was an intervention trial, and what we did is compare the intervention and post-intervention period with the pre-intervention period, and we were looking as our primary outcome at the rates of reperfusion, and we showed that the rates of reperfusion increased by 44% in the intervention and post-intervention period, which was a pretty amazing result.
Indeed, an amazing results. So you've trained more sites, so the key question now is, what about the implementation? So what do you expect in the future?
Well, the really encouraging thing is that even when the trial finished, those sites have continued to implement and use particularly the virtual reality training modules that we provided with them. So we have a natural experiment continuing in those sites, and that uptake, I think, really does suggest the acceptability, usability, and the likelihood that guidelines will, I think, move to recommend this as a method particularly suitable to the smaller hospitals that require more of that point of care, more sophisticated education. So we're hopeful that this can be adopted. The virtual reality technology is common now, and it's quite simple really to develop such a package that will be relevant to any community or any region. Obviously our packages sort of got an Australian flavour to it, but it would be relevant, I think, to many geographies around the world.
Thank you very much, and congratulations for the great achievements for this great trial. Thank you
very much.
Thank you.
So we're moving to the next trial, which will be covered by Professor Meinel, please.
Hello, everybody. So we're moving on to the PROMOTE trial, and it is a great pleasure and honor to welcome Professor Sheila Martins from Brazil and Professor Michael Braden from Austria, who are the co-PIs of this study, which tackled in primary prevention a polypill strategy as well as a risk app on your smartphone. So first of all, I want to express the compassion of the stroke community with what was happening in your country, and probably not an easy day with both a laughing and a sad eye. So can you maybe briefly elaborate on the motivation and aims of the study?
I think Michael is the perfect person to talk about this because it was his idea and the concept was created by Michael when he was the World Stroke Organization president.
Sheila is kind as always. No, the polypill idea goes back several decades to the 80s, and the idea is as simple as it is effective, that a conglomerate of several medications are put into one pill, and that's a polypill. And people take the polypill and not 3 different ones, 2 antihypertensives, 1 statin, and so on. So one polypill makes things easier. And in combination with the riskometer, Sheila could show that it is especially effective because the problem in primary prevention always was that people say, well, I'm a healthy person, why should I take a pill? But then with the riskometer, she could show to these patients that they do have a risk of stroke. And with this educational part, they were motivated to take part. Yeah. So I think it's an ideal combination, which obviously has worked out.
Excellent. For those who don't know the stroke riskometer, I highly encourage to download the app. It is very user intuitive. It provides nice visualization of your risk, and it motivates you to a healthier lifestyle. I tried it myself on the way here to Basel, so excellent. Can you elaborate on the population that you tackled? So I understand you included adults from 50 to 75 years, and I was a bit surprised about that you could include somebody with a blood pressure of 121. So after stroke, we're aiming for 130 or below, but then in primary prevention, you can include with 121. So what's the rationale behind this?
Yeah, this is very interesting because we already know that you need to treat patients with more than 140, and if they had a stroke or myocardial infarction after 130, but we know that the risk increase from 115, and is a continuous increasing of the risk. So the concept is treating these patients, we can decrease the risk of stroke, myocardial infarction, and other disease, and cognitive decline because they share the same risk factors. So this was the idea. The pilot was designed to prove that you can use medication in this population to see if the polypill was safe, if the patient can tolerate, if it's feasible to implement in primary care, and after this, as we show that really the treatment works, is safe, we can really see the main outcomes, that is stroke and cognitive decline, as primary endpoint in the major trial, and as secondary outcomes, myocardial infarction, cardiovascular death too.
You mentioned the efficacy, so you had a blood pressure reduction of 8.2 millimeter mercury. What is your expectation towards like MACE reduction in the larger phase, and what are the other endpoints that the study had?
Yeah, we know if you decrease 2.5 millimeters, we can decrease 10% of the risk of a stroke, so it's huge. And we decreasing 80 millimeters, comparing one group to another, we can the idea of Michael is cut the stroke in half, treating these patients, because really we believe that you can decrease in half the risk of these patients starting the lower blood pressure.
Maybe a question to the methodology. So I think, as I understand, there's a combination of 2 randomizations. So a cluster randomization as well as an individual randomization. So why did you choose this methodology and not randomize individuals as well to the riskometer?
This is a very good question. We discussed a lot this. We are worried with the contamination using riskometer in the same community, in the same primary care unit. And one talk to other and everybody start to use. So for this, initially we would randomize as cluster everybody for polypill also, but of course we have more power if you randomize individual patients, including the placebo. So we had this idea to use cluster for hiscometer and individual randomization for the polypill, and this sample size calculation was to evaluate the polypill, the safety to use and to expand. But it was really a challenge to do this because some primary care units have a smaller number, ones are ready to start and the others no. So the sample is not the same. So for the expansion of the trial, we need to discuss, Michael, with the executive committee, but probably we will randomize in 4 groups, individual patients.
Okay. So that might be a lesson learned, or were there other pitfalls of this pilot phase?
Exactly.
Were there other pitfalls in terms of implementation or rollout?
This population is not in the primary care unit, so we went there with the students to initial evaluation to train the nurse assistant that received the patient in the primary care unit. We stayed several days, weeks during the pandemic, but the patient were not there. The patient there is the hypertensive, diabetic, with prior myocardial infarction. This is not our population. So what we can do? So we start to call them through the media, social media, TV, radio, and also in the campaigns, we call them to the primary care unit to prevent stroke and myocardial infarction and dementia, and they start to come. So it was so incredible because the first year we include 150 patients. And after we learn, in 5 months we include the rest, 250 in 5 months. So really we learn a lot.
Wow, that is impressive and also exemplary, I think, for reach out to patients to get involved with research also if you are not in a setting where research is practiced on a daily basis. Impressive. Can you, I know it is a phase 2 study and it was not designed for that, but do you think the components, so what is more efficient? Is it the polypill? Is it the riscometer? I thought in the curves it's maybe more the polypill, or what are you expecting in the phase 3?
The polypill is more effective to reduce the blood pressure. To reduce the cholesterol, only polypill had effect. To reduce the blood pressure is strong, so really can decrease a lot with the polypill. But when we add the riscometer, we decrease more. So the best patients, the best result was polypill plus riscometer against usual care plus placebo. So really, I think riscometer add. And Michael told a very important thing about the improvement of all patients.
Yeah, well, the issue is that in primary prevention, the dropout rate usually is around 30%. And it was about 5, was it?
5 for adverse events, but in total was 15%.
Yeah, so much less than to be expected. And I think that's due to the educational effect of the riscometer. So it's a multiplicity of both. So you have to educate the people so they understand that they are at risk, and then they are motivated to participate. And so Sheila is very good at that, getting patients coming along and joining the trial. So I think this really worked out fine.
And maybe it's also a lesson for trialists to implement such e-health opportunities if it then enhances your trial quality with the data quality that you mentioned.
Absolutely, yes.
Can you maybe, I know we neurologists don't like it, but cardiology has done some polypill trials like
the polypill trials from cardiologists are secondary prevention. And for secondary prevention, the polypill has been accepted also by the WHO. It is now accepted in the list of essential medicines. So there is no discussion about that. But the issue is primary prevention, because there it can be even more effective. So we think that actually the number of strokes can be reduced by 50% around the world, around the globe. So that's the power of primary prevention, and that's the way to go, because if you need a recipe for one hypertensive, for another hypertensive, and for a statin, and the doctors are not always available, and the nurses are not allowed to give prescriptions, and so you have a polypill, you know. This makes life much easier for many people, especially in countries like Brazil, but in principle, Europe is not really different.
Can you comment, because I, as a physician in Switzerland, don't have the opportunity to prescribe a polypill yet. Can you comment on the availability of polypills?
Oh, you can prescribe. There is one licensed in Switzerland, but it's not covered by the insurance, so people have to buy it.
Okay.
Is the very low cost. This polypill is $4 per month per patient. That is a low cost polypill. And the discussion with the minister that we have a company to produce a public one. In 5 years, the medication will be property for the Ministry of Health to give for free for the population.
Yeah, that's the plan.
That's excellent.
Yeah. I'm sure in Switzerland it's not so cheap.
We'll see. Okay, are there any things that you want to add about the trial? Anything that didn't come up that you think it is important to the viewers?
Well, I'm so proud because I think really this can have a huge impact in our population. And after the patient is engaged, they believe that they can improve. It's not only this, we have a team to motivate the patient and to help them to modify lifestyle. It's very important for this. His committee is important to show that it's feasible to do this.
Well, thank you so much, Professor Martens, Professor Brainin, for joining. For the viewers, I wish you a nice evening. Enjoy the after ESOC parties. Make sure to come tomorrow to the interesting program. And for those watching online, and enjoy some more ESO content in the ESO channel. Thank you. Bye.